All right. So I hope that people can hear me. Welcome again to our second webinar. My name is Harry Papadopoulos, and I am the past president of ACSM Northwest. And this is, as I mentioned, our second webinar of the webinar series that is supported by a grant by the ACSM. Before I make introductions of Dr. Rosenberg, I would like to remind everyone that our ACSM Northwest Conference will be on February 28th and 29th at the beautiful campus of Boise State University. Our abstract submission is open, and you have until December 13th to submit your abstracts. And also registration for the conference is also open for the 2020 annual conference. I also want to remind people, if they have not seen that one, that our next webinar will be on December 10th at 10 a.m. Pacific Standard Time. And Dr. Walter Thompson will be presenting on the American Fitness Index. So without any further ado, I would like to introduce our presenter. Dr. Rosenberg is an associate scientific investigator at the Kaiser Permanente Washington Health Research Institute and is an affiliate associate professor with the University of Washington, the Department of Health Services. She has conducted extensive research on physical activity and sedentary time among older adults and populations with chronic conditions. She completed her PhD in clinical psychology and behavioral medicine at the University of California, San Diego and San Diego State University. She's currently the principal investigator of the Healthy Aging Resources to Thrive trial, where she's testing the efficacy of a seating reduction intervention for older adults. Her talk today is wearable devices in sedentary behavior and physical activity research. Dr. Rosenberg, the floor is yours.
Thank you. Great. So today I just want to disclose that I have no conflicts of interest, but I am an aging and chronic disease researcher, as Harry mentioned. So the examples that I have to share are more from that literature. And I also use Fitbit, Garmin, Actigraph, and ActivePal in my studies. So again, I just have the most experience working with those devices. So today I'll just do some brief background, and then we'll talk about different wearable device options that are out there for research, both for measurement and interventions. And then I'll share some examples of studies, an epidemiologic study that I work with, sedentary behavior interventions that I've done, and some physical activity interventions in prostate cancer survivors and people who've had bariatric surgery. So as I'm sure all of you know, physical activity is good for us. It prevents, controls, and treats many chronic diseases, reduces mortality. It also improves physical and cognitive function, quality of life, and mental health. And the 2018 physical activity guidelines suggest that adults need 150 to 300 minutes of moderate intensity physical activity, or 75 to 150 minutes of vigorous intensity physical activity. And the guidelines state that this should ideally be spread throughout the week. In addition, the 2018 physical activity guidelines underscore the importance of sedentary behavior and kind of considering that behavior in its own right. So the guidelines now explicitly state that adults should move more and sit less throughout the day, and that adults who sit less and do any amount of moderate to vigorous physical activity gain some health benefits. And so in this talk, I will be not only talking about devices for physical activity, but for sedentary behavior. And I do a lot of research in that space, so I'll have some examples for you in that arena. So why should we use devices? You know, self-reports aren't necessarily bad. They are inexpensive. They help us understand different types of physical activities that people do. They also can help us kind of divide people into inactive versus active. So they're not necessarily bad. They do have limitations, however. So self-reports are limited for helping us really more accurately understand intensity of physical activity. They're also limited in helping us understand sedentary behaviors because it's very hard for people to think about all the time they spend sedentary throughout the day and add that up in their mind. And they're also limited for helping us understand patterns of both types of behaviors. For interventions, they hold the promise of helping us develop more scalable approaches that are less expensive and less burdensome. They also provide regular feedback to people on their behavior, and we know that that's an important kind of theoretical construct that mediates our intervention effects. And then there's the hope of being able to develop just in time adaptive interventions, which are interventions that aim to provide the right type or amount of support at the right time by adapting to individuals' changing internal and contextual states. So I just want to talk about some of the different devices that are out there for measuring and intervening on physical activity and sedentary time. So the first kind of wearable device that I think of is just a simple pedometer. Pedometers can be great for some reasons. They're inexpensive. You can get very good, accurate pedometers for $15 to $25. They are very valid for measuring steps. They're accurate at slow speeds, which is important in studies that intervene with older adults. They're very usable. People don't mind using and wearing them. They find them simple. They don't have a lot of buttons or complicating features. They provide one simple metric, steps per day, which is really easy for people to interpret and understand. They don't require any data processing. Some of the negatives with pedometers are that they don't estimate cycling, swimming, or weight training. They're good at measuring movement that includes hip motion, and so those activities aren't really counted. They can also be lost because we've had a lot of reports in our studies where people put them through the wash or they fall off. They're also a little bit harder to use for measurement. They tell somebody feedback on their behavior, which we don't want when we're trying to measure behavior. And so you have to blind them. We've used tape, but it's not ideal as a measurement device. For interventions, people have to manually keep track of their counts over time. Some pedometers do have memories of 7 or 28 days, but generally people have to write down their counts to see their progress over time. And they don't offer any metrics other than steps. But there's more and more studies relating steps to health outcomes. And so while we know that intensities of physical activity are associated with health outcomes, there's a little bit less data on steps. This was a recent study showing that more steps per day was associated with reduced hazard ratios for all-cause mortality. And so steps are being associated with important health outcomes and are an important metric that the public understands, which I think is really key. And interventions are pretty effective. In adults, they improve steps by about 2,500 steps per day. They perform a little bit worse in older adult populations or populations with chronic conditions, but still pretty reasonable and significant improvements in steps. Then there are commercially available fitness trackers like Fitbit, Garmin, and Apple Watches. These are kind of medium in cost, which could be a pro or a con. There is some evidence that they're accurate for measuring things like steps, although they can overestimate. They're very usable. People generally wear them on their wrist like a watch, and so there's not a lot of barriers to wearing them and using them. They can be more complicated to use, but generally people find them pretty easy to use. You can pair them with an app to track your trends over time, and they provide information on more than just steps. They often provide information on heart rate, sleep, and active time. And it seems like people comply reasonably with wearing these devices. And this is just an example of a study that was a 12-week Fitbit study where people had a very light touch intervention where they just got some reminders each week to wear their Fitbit. And over the 12-week study, adherence to wearing the Fitbit was over 87%. And so it seems like people are in the context of interventions at least willing to wear the device for the duration of the intervention. Some of the cons are that these devices tend to work not as well at slow walking speeds. They can underestimate steps. Be a problem if you're working with populations who are older or who have disabilities. They don't assess sedentary time very well. You have to use an API or a service to extract the data if you want the data for your own purposes. There are limited features if you're working with a population that doesn't have access to a smartphone or a web app where they can sync their data. So I, for example, use a lot of these in my studies with older adults. They don't all have smartphones, and so they're limited to kind of using what's on the device itself, which is often just daily step count. The algorithms that these companies use to determine the outcome metrics are proprietary, so we don't know how Fitbit transforms their data into a step count or into active minutes. And the raw data is also not typically shared with researchers. In addition, the software can change without warning, and that can cause problems if you're relying on the device data. There was a recent review of fitness tracker randomized control trials, which found generally some positive but small effects on behavior. So these studies found significant improvement in steps and a significant improvement in moderate to vigorous physical activity. There was a non-significant decrease in sedentary behavior, but some of the limitations were that the quality of the evidence was very low. The vast majority of studies were less than 6 months and did not have very large sample sizes, and there were very few studies in populations with chronic conditions, where I think we have a lot of hope to use these devices, as we'll talk more about later. And then there are research-grade accelerometers like Actigraph and the Genie Active. These are typically worn on the wrist or the hip. They do store long periods of data, which is nice for researchers. They can capture information on detailed patterns of behavior as well as intensity of physical activity. Raw data are typically available for researchers to use and do things like apply machine learning algorithms. And they work well for measurement and epidemiologic studies because they typically don't provide feedback to the person wearing the device. They're kind of black boxes. Some of the cons are that they can get quite expensive. They measure movement and a lack of movement, and they don't measure posture, and so that can be a limitation for studies of sedentary behavior and sitting time. They're also less ideal for intervention studies because they're pretty black box and don't provide much feedback to users. Some devices do provide user feedback, but these devices do tend to be a little bit bulkier to wear, so they're not kind of as usable as things that are commercially available. They do require a lot of processing and data reduction. The ones that are worn around the waist can be uncomfortable for some people, like populations with obesity. Physical activity can be underestimated at slow walking speeds. Now there are also posture-based devices like ActivePal and Activity, and these are nice because they clearly distinguish sitting compared to upright postures, so you get really good information on sitting time and patterns of sitting. They also do measure steps and cycling pretty well, including at slow walking speeds. And we think the patterns of sedentary behavior are important because if you think of 3 people who have generally the same amount of total sitting time, the way they break up their sitting time can be quite different. So the person on the bottom is getting up very regularly and has very short bouts of sitting, whereas the person on the top has a lot of longer sitting bouts. And you can summarize these sitting bouts by counting the number of sit to stand transitions, by looking at the mean bout duration of sitting bouts, and you can also count the number of prolonged sitting bouts that last, say, more than 30 minutes. So there's a lot of different kind of sitting pattern metrics we can look at with these devices. Some of the cons are that they're also processing intensive. Typically, we waterproof them ourselves and adhere them to people's thighs so that they're not taking them off and on, which can be a problem with compliance. So we just kind of stick them on people and say wear it for 7 days and don't remove it. But it does take a little bit of work to do that, and some people don't like having tape on their thigh. But typically, we're finding that people put them on and pretty much forget about them. So it's not working as badly as it could be. Battery life is more limited with these devices. I think they work for anywhere from like 14 to 21 days. And they don't have Bluetooth yet. Some of the overarching device issues are reactivity, so people can be more active when wearing devices, which can be a problem if you're just trying to measure or monitor behavior. Recordings are impacted by seasonality and week-to-week variation, although we typically only have people wear them for 7 days at a time. And so you're not necessarily capturing all of the variation that can occur within individuals. You also have to deal with sleep and non-wear non-compliance. Typically, we remove that time from our data. In addition, they're poor at estimating physical activity during cycling, swimming, or weight training. They're limited for identifying types of physical activity like walking or using cycling, but new machine learned algorithms are starting to help us identify types of physical activity, which is great. And they require intensive data processing. So now I'll get into some examples of studies using devices. I'll start by sharing an example in the epidemiologic literature space. So I've been working with an ongoing cohort study here at KP Kaiser Permanente, Washington, called the Adult Changes in Thought, or ACT cohort. This cohort's been going on for over 2 decades. We've had over 5,600 people over age 65 enrolled over time, and we hold the cohort steady at an active 2,000 participants. And this cohort is very well characterized. We have all of their medical record data going back decades. We also have them come in for biennial in-person visits where we do a lot of assessments. We collect some blood measures, and then we recently added measures of physical activity and sedentary time. We have a lot of sub-studies, including a pharmacoepidemiology sub-study, a traumatic brain injury sub-study, and people can donate their brain to our research after they die, and we have a neuropathology study as well. So it's a really rich cohort. And in the adult changes in thought cohort, we also wanted to add measures of sedentary behavior and physical activity. And we were really interested in detailed patterns of both behaviors. So we decided to kind of use field gold standard measures for the 2 different types of behaviors. So we're measuring sedentary time and standing time with the ActiPal, because ActiPal, like I mentioned, really nicely distinguishes sitting from standing. And then we measure light intensity and moderate to vigorous intensity physical activity with the Actigraph worn around the waist. And so people are consented at their biennial visits to wear both one or the other or neither device. And just to show you the steps we have to go through to process the data, we have to identify and remove in-bed time based on sleep logs and wear logs. We then visualize the data, and we typically visualize a heat map, and we have to review every single heat map for every person in the study to make sure that their data look normal and identify any problems. We then apply algorithms so that we can create our meaningful output variables. And then we have to identify valid data, and we identify a valid wear as 4 or more days with 10 or more hours of awake wear time. And then we summarize the data. So for actigraph, we look at sedentary time and minutes of light and moderate to vigorous intensity physical activity. And for ActivePal, we have measures of total time spent sitting, standing, and stepping, total steps, sit to stand transitions, prolonged sitting bouts, and mean duration of sitting bouts. And just to show you the data that we're getting out of this, we have almost 1,000 people that have worn both devices and have valid data, and they do over 10 hours per day of sitting, and that increases with age, and men sit more than women. They're also doing 6,300 steps per day, so they're not completely inactive, but physical activity does decline with age, and men are a little bit more active than women. The mean sitting bout duration is 17 minutes, and that increases with age. Sedentary time measured by actigraph is a little bit less than sitting time measured by ActivePal, but we see a similar pattern whereby it increases with age. Light intensity physical activity is about 4.5 hours per day, so they're doing a lot of light physical activity. And moderate to vigorous intensity physical activity is about an hour per day, which is quite high, although it decreases with age. Some interesting patterns that we're seeing with our data, and we'll be looking at how this relates to different health outcomes. Just as an example, if we look at the ActivePal data by self-rated health status, the dark green bar is sitting, and then standing, stepping, and in bed time. And what we see is that people with fair to poor self-rated health have much higher percent of their day spent sitting, less time standing and stepping, and more in bed time. And we see a similar pattern with other health metrics. There's a lot of international studies collecting accelerometer device data with research-grade accelerometers. So we'll be able to compare our data and potentially merge our data with some of these studies. And in the future, we hope to also measure sleep with kind of a field gold standard device and really look at kind of the 24-hour day and how sleep affects sitting and physical activity and vice versa. Now I'll kind of shift towards interventions and first talk about some of the sedentary behavior intervention work my team has been doing using wearable devices. And so we've targeted older adults for this work because the prevalence of obesity is very high in older adults, and very few are meeting physical activity guidelines, and average sitting time or sedentary time is quite high. And so we wanted to develop an intervention called iStand to reduce sedentary time and see if an approach to get older adults to break up their sitting more often by standing more and moving more could be an effective way to engage them in a health-promoting intervention. So we use wearable devices in a couple of different ways. The first way is we know that giving people accurate feedback on their sitting time is really important. Most people aren't very aware of how much sitting they do, and so getting feedback from objective devices is very eye-opening. So we want people to understand their baseline level of sitting and be able to track over time whether their goals are met. A key limitation, however, is that there are no real-time tools that provide feedback on sitting time. We actually did some focus groups where we had older adults that had been in one of our pilot interventions vision what they would want wearable devices to look like and what feedback they would want the device to give them, and these are some images they drew for us. But because there are no real-time tools, what we've turned to is giving them delayed feedback from wearing the ActivePal, and that's because we know ActivePal is very accurate, and we know that older adults value getting accurate feedback. And so it's a little bit of a pain, but what we've done is we've visualized the ActivePal data from when they wear it for a baseline week, let's say, and then we show them kind of what their patterns were. So we show them their standing time and sitting time They're 30-minute periods of sitting, breaks from sitting, stepping, and step counts, and we give them a goal, which is usually an hour per day reduction in sitting time. And then we also visualize the data so they can see kind of each day of the week and compare days and look for days with high and low sitting time. And then the other way we're using wearable devices is we know that people get really engrossed in what they do when they're sitting. For example, I've been really engrossed in giving this talk, and I've been sitting the whole time. And now would be a great time, I think we're about halfway through, for everybody to get up and take a break from sitting if you're sitting and wiggle around a bit. I am doing that right now. But we forget. We sit and we're doing things and we're engrossed. And so we know that it's really important to give people frequent reminders to take breaks from sitting. And a lot of commercially available devices have inactivity alert features, which we can kind of repurpose as a way to get people to think about their sitting, whether they're sitting and if they are to take a break. We actually did a nice little study using an ABA single case design experiment where we wanted to really hone in on the efficacy of commercially available devices inactivity alert features to improve sit-to-stand transitions in older adults. And these are really nice study designs because they're kind of efficient ways of looking at the impact of a technology on behavior. And so another way that technology helps us is in being able to kind of use some of these neat designs. So what we did is we had people wear an ActivePal for the whole study, and at first they were just monitored. We just had them wear the ActivePal. There was no intervention. Then at some random length of time, we gave them a wrist-worn device, the Jawbone Up Band, where we set it to go off every 15 minutes, and we instructed them to take a 1 to 2 minute break from sitting every time it went off. We then took that device away and continued to monitor their behavior, and they were in the study for up to 25 days. And what we found is during the baseline monitoring phase, they got about 60 breaks from sitting per day. That went up to 66 breaks from sitting during the phase where we gave them the Jawbone, and then that went down to about 57 breaks from sitting per day after we removed the device, and this difference was significant. So we did show that actually these inactivity alert features set to go off very frequently can effectively promote more breaks from sitting, although the effect was only about 6 breaks per day, so not a huge effect. But we did qualitative research, and we found that we thought we might drive people nuts if we were prompting them every 15 minutes. But in fact, people really liked it, and were sad to see the Jawbone go. So that was good news. They also were willing to wear the ActivePal for a pretty long period of time. Some of the limitations of our study are that we don't know if people took breaks after receiving an alert. There were only 10 people in our study, although we were powered to see changes in behavior, but our change in behavior wasn't huge. So based on that study, as well as some prior pilot studies that we did, we wanted to really combine into a package an intervention called iStand to really see if it was efficacious for reducing sitting time compared to a control condition over 12 weeks. And we also did some qualitative work to see how people liked the intervention. So the intervention consisted of 2 in-person sessions and 4 follow-up phone calls, a Jawbone Up Band to prompt breaks from sitting, ActivePal feedback, like I mentioned before. We gave them delayed feedback at week 1, 2, and halfway through the study period. And their goal was to reduce sitting by 60 minutes per day. And our control group had 1 in-person session with a health coach where they picked topics from a healthy living workbook to work on over the 12 weeks. Our outcomes were ActivePal measured sitting time, standing time, prolonged sitting bouts lasting more than 30 minutes, and step counts. And what we found is, so the next few slides look like this. So the iSTAND group is on the left, baselines in the dark blue, and follow-up measures are in the lighter blue. And what we found was a significant reduction in sitting in the iSTAND group compared to the healthy living group. So the iSTAND group had a reduction of about 54 minutes per day in their sitting time, so we came really close to meeting our hour per day reduction. And there was no change in sitting time in the healthy living group. Concomitantly, we found that there was an increase in standing time in the iSTAND group of about 40 minutes per day, with no change in the healthy living group. 30-minute bouts of sitting went down in the iSTAND group compared to no change in the healthy living group. And steps went up a very small amount in the iSTAND group, but this was not significant. There was no change in the healthy living group. And so we found that overall, these wearable devices really supported sedentary behavior reduction, but that a major limitation is that we don't have real-time tools. And I think using things like Fitbit, you could actually, and focusing on steps, you could actually miss people who are willing to sit less just by standing more. And so this population seemed really amenable to standing more, but not necessarily moving much more. People were also willing to use devices that prompted them very frequently, and we did some qualitative work with this study that showed that people really liked how the devices fit into their daily life, and they liked the focus on sitting less. Although I think in the future we could do even better by sending people more tailored and personalized messages based on where they are and the weather and taking other things into account. Now I want to turn to physical activity interventions that I've been working on with colleagues and collaborators in two main patient groups. The first group is men with prostate cancer. We focused on that group because men with prostate cancer have low levels of physical activity, and physical activity has really been shown to improve survival in prostate cancer as well as reduce many side effects of prostate cancer treatment. But most of the interventions have been really intensive supervised exercise programs, and we wanted to see if we could develop something more scalable that could kind of fit into clinical care. And then for the bariatric surgery population, that was a target because, interestingly, people undergoing bariatric surgery often think that they'll be able to be more active following surgery, but the data actually show that physical activity doesn't change very much pre- and post-surgery. And so again, we thought this is a population where a more scalable intervention that could fit into clinical care would be really useful. So in the work with prostate cancer, the first study we did was just a 3-week field test of the Fitbit Zip tracker. We just had men use the device as much or as little as they wanted, and then we did interviews about the usability of the device. The men reported that it was really easy to use and wear. They were really interested in the data. Many of them felt like they were already very active, even though our objective data that we collected showed that they were pretty inactive. So the Fitbit could provide some disappointing information. And there were some technology difficulties when people tried to sync the device with the Fitbit app or website. But the men were also really willing to share the data with their healthcare team, which was good news to us. We went on to want to design a social media intervention, including Fitbit, for men with prostate cancer. And this work was led by my collaborator, Andrea Hartzler, at the University of Washington. We did 3 focus groups first before developing the intervention, and we found we had proposed using a leaderboard, but the men actually found that they really didn't want competitive content. They wanted to emphasize social support and supporting one another. They wanted group walks. They wanted high-quality educational content. And there were some concerns and low use of social media, but we thought we would give it a try and see what people thought of it after trying the intervention. And so we gave people a kickoff session with some training in using Facebook and Fitbit. They set some goals for using their device, and their ultimate goal was to increase their steps by 1,500 steps per day over 6 weeks. They selected a walking buddy to support them, and then we had a private Facebook group with educational materials and prompts for engagement. And what we found, we covered their Fitbit for a baseline week of monitoring, and we found about 4,300 steps per day, which went up over the 6 weeks to over 6,800 steps per day. So they improved their steps by about 2,500 steps per day, which exceeded our target. And then Facebook interactions started off pretty high, but tailed off pretty steeply over the 6 weeks and ended up very low. We did find that people really liked the Fitbit, like similarly to what we had found earlier, but people did not love Facebook. They were discouraged by low posting, they had privacy concerns, and they kind of felt like they didn't know each other, so it was a little bit harder or less enticing to use. Then the other study I want to share is a program we've been developing called BariFit, which is mobile health tools to promote physical activity after bariatric surgery. And this work is led by my collaborator here at KP, Peja Klajna. And we worked with the bariatric surgery team at KP Washington, and we developed this program with them. They helped us recruit 50 people 2 months post-surgery. They then received a digital scale, a Fitbit Charge HR, and the Fitbit app to use for 4 months. And we sent them 2 types of text messages. So first, we sent them daily adaptive step goals, and they were randomized at the beginning of the study to get fixed adaptive step goals or variable adaptive step goals. And the fixed adaptive step goals meant that they received a goal each day, each morning, that was the 60th percentile of the prior 10 days of steps. And the variable adaptive step goals meant that we randomized them to receive either the 50th, 70th, 90th, or 120th percentile of the prior 10 days steps. They then also got text messages with suggestions to walk or sit less. They picked some preferred times of day, 5 times of day, and then we randomized them at each of those time points whether or not they'd receive a message. So then on average, they received 1.5 messages per day so that it wasn't overly burdensome, and we could embed a little micro-randomized trial into the study, which is kind of another neat study design you can use with technology. And so we use ActivePal as our measure of steps at baseline and then at 4 months. And if you look at the bars on the left and right side of this slide, you'll see that steps increased from about 5,100 steps per day at baseline to 7,100 steps per day at 4 months. And we also just explored the first 2 weeks of using the Fitbit compared to the last 2 weeks of using the Fitbit. And that data really suggests that people made the most changes right at the beginning of the intervention, but they were able to sustain those changes, which was good news to us. And we also found high adherence to using the Fitbit and tracking steps. So adherence only went down a small bit at 4 months, but overall was really high. So older adults and populations with chronic conditions and surgical populations can use technologies, and I think are great target populations because they're particularly at risk for low physical activity. And so I'd love to get more towards being able to use some of these interventions in clinical care to help promote physical activity in higher risk populations. We also have found that giving people more support for how to use the technologies, especially going with older populations, can be really helpful. And if you do have the ability to add in-person support, it can help even more. We also think that life events or transitions may increase technology uptake and the uptake of interventions, so targeting those transitions can be important. And I think we can better refine mobile approaches. We can tailor based on context. I have a colleague whose work has shown that prompting people to be more active when they're at home or at work is much more effective than prompting people when they're in other locations, probably because they're in other locations where they aren't able to do some movement. And some overall conclusions, there are a lot of wearable devices out there. And so figuring out the best one for your work is tricky. It's important to pick a device that matches your objectives. If you're interested in sedentary behavior, then a posture device might make more sense. But if you're interested in intensities of physical activity, a research-grade accelerometer might make more sense. Device location is also important. So, for example, the National Health and Nutrition Examination Survey, the NHANES, recently, in the last few years, they've been using accelerometers around the waist to measure physical activity objectively in that national sample, but they switched to the wrist because they wanted to get better compliance. And so that is a consideration. In addition, using wrist devices, you can get sleep data. And so if you really are interested in sleep, that might be important. But I also think that practical considerations are important to take account of, like your budget and simplicity. And so sometimes I think, we've moved away from pedometers and we're using these more expensive wearable devices, but I don't know how much we gain all the time from using those because pedometers actually work quite well for many people. And then it's important to engage programmers and analysts early and to adequately budget. They are a really important part of using devices, and it often takes longer to process the data or capture the data that you want than you've expected. And so just making sure to adequately do that. And then engaging stakeholders. I think you learn a lot from the qualitative side of this work, and that's really helpful. And then finally, note when you're using these devices that sensors and software can change at any time. So for example, now there's this movement towards using wearable fitness sensors like t-shirts, socks, rings that are embedded with sensors. There are smart patches. So things are always changing. In addition, the software can change overnight. So I had a friend who created this really nice user manual for the Fitbit she was using in a study. And then overnight, Fitbit changed their design of their dashboard. And that totally messed up the book she had created for her participants. So she had to rush and scramble to redo that. And so these companies that aren't research companies don't have an incentive to let researchers know when they're changing things, and so it can happen at any time and can create problems. And then I just want to acknowledge collaborators on these studies and my funding from NIH. Now I'm happy to take questions and comments.
Okay. Dr. Rosenberg, thank you. So I want to remind all of our attendees that there is a question mark on the top of your screen. So if you press that one, then you can type your question, and then I can post that question to the presenter, and she can respond to that one. So with that, I have one question already been posted, and I will just read this one for you, Dori. It says, is there evidence of the effect of wearables on physical activity? Meaning, does the act of wearing a device directly affect spontaneous physical activity?
Yeah, that's a great question. And that's tricky to answer because the studies in that review of RCTs using wearable trackers, they all use different approaches and weren't pure studies of just using a fitness tracker. And so, I don't know that there's great evidence on just using the tracker alone with no other intervention and whether that changes behavior. But I think the studies that have been done typically do some prompting to remind people to wear the device, or they give them some sessions with a health coach, so they're combined with other elements. And those are the studies that have shown really good adherence to using the wearable devices. But just giving people the devices, there was one study I found that said that there is some effect on reactivity to just giving people a device. So people do seem to be a little bit more active when you just give them a device, but I don't think we know if that is sustained over long periods of time. And I have a feeling that for some people, giving them a fitness tracker is probably all they need to be more active and stay on top of their physical activity. But a lot of people need more than just a tracker. They need some support, they need accountability. And so I think the other thing we can do with our studies here is figure out, who are the populations that just need these technologies? And then who are the people that need more? And how do we target different interventions to those different groups of people? And so, because giving people these trackers is a pretty low cost, easy thing to do if you are giving them to a population that that's sufficient for. But knowing who would be the people that need more, I think, would be really interesting, and understanding the characteristics of those individuals would be really interesting.
Okay. I have another question. Are these wearable devices that you mentioned better at monitoring sedentary time or physical activity, and other differences between those devices?
I don't know which devices this person is talking about specifically, but as I mentioned, for the measurement devices like ActivePal versus Actigraph, Actigraph is a accelerometer that measures movement and a lack of movement, whereas ActivePal has a posture sensor in it, so it's able to tell us if people are sitting or standing and moving. And so those devices are measuring different things. So the Actigraph, for example, would be better at physical activity, and the ActivePal would be better at something like sedentary behavior. For the commercial devices like Fitbit and pedometers, those are all measures of physical activity and don't currently measure sedentary behavior very accurately. And so, that was the problem I was mentioning around the difficulty that sedentary behavior researchers have around there being no kind of real-time tools that measure sedentary time.
Okay. Another question is, with the popularity of these wearable devices, as a researcher, and I know that's probably mostly you've done with the research, if someone wants to invest at one of those wearable devices, are there any recommendations?
Yeah, I don't think there's like a clear leader yet. I think what I've done in my studies, I use, like I mentioned, I've used pedometers, Fitbits, Garmin's, and I've really tried to match the device that I pick to what the intervention is and to who my target population is. So I'll give an example of this. I have a study in older adults over 70 where we're trying to prevent dementia by encouraging more walking in addition to other health behavior changes, and we wanted to pick a device for that population. And I thought, this is an older population, substantially older population, that may or may not have a smartphone, and they're probably most interested in their step counts. And so I went with a device, the Garmin VivoFit device, because for a couple of reasons. It doesn't require any charging, so it has a battery, that lasts for I think 6 months. And I thought, well, this is an older population. Having something they don't have to charge and remember to charge could be really important. It's waterproof, so you can just wear it all the time without having to take it off for showering, for example. It gives one simple, easy metric steps. If they don't sync it to a smartphone, they still can get their step count and track it over time. And if they do have a smartphone, great. They can sync it with the app and get their trend data and their sleep data. So I picked the device that kind of matched our population rather than maybe the device like a Fitbit that's really the most commonly used wearable device right now in studies. But I think you really have to think about your research question and your target population to pick the right device. I don't think there is one right device. If I were doing a sleep study, I might pick a different device than a non-sleep study. So there's a lot of considerations to think about when you're choosing. And the final consideration I'll just mention is cost, because you may not be able to afford, Fitbit Versas for everybody, even if you want that. So the Garmin VivoFit was also more reasonably priced than a lot of the Fitbits, and that was a consideration for our project.
Okay. So I would like to thank you, Dr. Rosenberg, for this nice presentation. I would like to remind our attendees that our next webinar will be on December 10th, and Dr. Walter Thompson is going to be talking about the American Fitness Index. So I wish to everyone that joined us today a very happy Thanksgiving. And I want to remind you that we have been recording this webinar, so then we will post it on the ACSM's YouTube channel and for you to view it again if you want to, or maybe share it with other individuals. So thank you for joining us this afternoon, and wish you again happy Thanksgiving. Thank you.